Okay, there we go. All right, well, welcome again, everybody, to this, this really great EQIP webinar on sepsis. So first, I'd like to introduce our speaker. Our speaker today is Kara Downing. She's a nurse, and she's got lots of great experience in acute care hospitals, specifically related to sepsis. She's worked in oncology, critical care, and ED, and in quality, so she's got a great breadth of experience and working with really fragile populations. The last 6 years, she has been a sepsis coordinator for a large health system, facilitating best practice among multidisciplinary teams across multiple sites to include standalone EDs and critical access hospitals. Currently, Kara is the infection prevention coordinator at Capital Medical Center, which is in Olympia. She has her Associate of Science in Nursing and her Bachelor's of Health Science in Gerontology. Her passion is keeping abreast of best practices and new research and implementing change to provide quality patient care. Kara is married and recently moved to Washington with her husband and 5 dog friends. All right, well, welcome, Kara. So I am going to turn it over to you. I will be moving your slides forward, so just give me a cue whenever you'd like me to move forward. But with that, I am going to introduce you, Kara, and turn it over to you. Thank you.
Thank you so much. And it's really an appropriate time to talk about sepsis, as it is Sepsis Month, and yesterday was World Sepsis Day. So this was really appropriate. I wanted to start our lecture today, our chat today, with a little film. It's 6 minutes long, and it really helps ground why we do the work we do as IPs, or as like I did before as a sepsis coordinator. It makes us think about why we step up to the plate and do the jobs we do. So I wanted to start with that.
All right, Kara, hopefully I stopped it at the right time. I'm going to go back to your slideshow. Okay, and Kara, are you still on the line? Oh, she's muted, I think. There we go. Hi, Kara, are you?
I'm still here.
Okay, so I think I accidentally muted you. I apologize. And I hope folks were able to hear that really impactful video.
I hope so. And if not, I can send the link out to everyone. It's a video that we actually use at our nursing orientation every month. And it sets up the conversation for infection control, why we need to wash our hands, why we need to do aseptic technique, and then a little chat on sepsis for our nurses. So Patty was right. This is Sepsis Awareness Month. And the reason why we're chatting about it is because mortality is really high. 80% of the deaths can be prevented with rapid diagnosis. Sepsis can be the #1 readmission reason to your hospital that costs a lot of money. A large amount of people with sepsis are readmitted within 30 days. And 92% of the sepsis cases originate in the community, meaning that it's not a nosocomial infection, but they're coming through our ERs and clinics to find us. And the saddest thing is just 55% of the US adults have actually heard of sepsis, and that number came from the CDC. We can go to the next slide. So sepsis is the leading cause of death in US hospitals, and the deaths from sepsis have killed more people than AIDS or breast cancer together. And as our population ages, we actually have a greater number of people that are susceptible because they're aging, because they have immunosuppression from chemotherapy or transplants or serious comorbidities like diabetes, which is a large number of our patients, because they've had invasive medical treatments or they have drug-resistant organisms. Next slide. So I wanted to do a little bit of history for you. So the Surviving Sepsis campaign started in the early 2000s, and it really provides the guidelines for best practice for sepsis care. In 2004, it's an international collaborative that was brought together to improve the treatment of severe sepsis and septic shock with the goal of reducing mortality. They updated their guidelines in 2008, 2010, 2012, and in 2016. Next slide. The Surviving Sepsis campaign, it came out with bundled care. It used to be called early goal-directed therapy, and that was for rapid diagnosis and treatment. And the education that went out to hospitals was, here's this bundled care, this set of best practices that if we do it together, will save lives and decrease mortality. Next slide. So over the last decade plus, what you probably have seen regarding sepsis is something very similar to what's on the screen now. You start with SIRS. The patient has to have 2 of the 4 SIRS, plus an infection or a suspected infection, and then they have sepsis. And then they have severe sepsis if they have end organ damage, they have hypotension, or they have a lactate over 2. That one's actually incorrect on this slide. And then septic shock is where they have hypotension after you have given them the bolus, or a lactate over 4. And that's pretty much been what sepsis has been for, like I said, the last decade plus. In 2014, some research came out that showed that maybe this isn't the best way to think about sepsis. And you can go to the next slide. And based on that research, the Surviving Sepsis guidelines actually updated their definition for sepsis and their naming of sepsis. So whereas before we had like layers, SIRS, sepsis, severe sepsis, septic shock, what they define sepsis as now is sepsis, which was in the past known as severe sepsis, is a life-threatening organ dysfunction caused by a dysregulated host response to the infection. And the severity of that response is dependent on the host, on your patient, more so than the causative organism. So that's why patients, when they come in, each one will actually look a little bit different, even if they have the same underlying organism, like MRSA. It depends on their body as to how sick they will get. And the second definition is septic shock, which they now define it as a subset of sepsis with circulatory and cellular metabolic dysfunction associated with a higher risk of mortality. And that higher risk of mortality is actually a very interesting piece of the definition that we'll chat about a little bit later. Next slide. So sepsis, talking about it as it is defined now, is an infection, any type of an infection, with acute organ dysfunction. So that could be a pneumonia patient that has a lactate of 3.5, or a pneumonia patient who's hypotensive, or a pneumonia patient whose bilirubin is up, and that's brand new for this patient for whatever reason. Those would be examples of what we would now refer to as a sepsis patient. And at the cellular level, during this sepsis event, there's inflammation going on, which causes increased capillary permeability with third spacing. There's coagulopathy with clot formation in the microcirculation going on, and impaired thrombolysis. So what that leads to is a maldistribution of blood flow, and there's severe hypoperfusion of the organ systems, which is evident by your acute organ dysfunction, and massive vasodilation, which would be your septic shock. Next slide. So septic shock, the subset of sepsis with hypotension, despite the fact that you've given the patient the adequate amount of bolus, is acute circulatory failure. It does require vasopressor support, and it is either the hypotension after the bolus or a lactate of equal to or over 4, regardless of what the blood pressure is. An untreated septic shock is 100% fatal. Next slide. So why should we be talking about sepsis? Because early recognition and prompt treatment does save lives. The standard screening tools help to identify those patients early, and that treatment, the bundled care, it is simple. It just needs to be done in a timely manner. Next slide. So sepsis is sneaky. It's one of the reasons that I like it so much, because the symptoms can be vague and they can mimic other conditions. You could have a patient come in, I'll go back to the pneumonia patient, that has pneumonia, is walking, talking, has a bad cough, maybe a fever, and they were tachycardic, and they have a lactate of 3, but they're walkie-talkie. And you can have that same scenario come in, and the patient is requiring respiratory support and needing more resources from you. So many high-risk patients already look ill already, and sometimes the development of sepsis doesn't require that the patient be bacteremic or have endovascular infection. So really the bottom line is we need to have a high index of suspicion for sepsis for all of our high-risk patients. Next slide. So who's most at risk for sepsis? A person that had recent surgery or an invasive procedure, nursing home residents, underlying comorbidities like we talked about before, diabetes, cardiac problems, lung, liver disease, the elderly over 60, also the young under 3 months of age. Those with chronic renal failure, those with drug or alcohol abuse problems, persons undergoing treatment for cancer because they're immunocompromised, and transplant patients. Next slide. So for early recognition, to start the thought process of sepsis, the patient must have an infection or you suspect an infection. And the number one infection seen with sepsis is respiratory infections, followed by urinary tract infections, and not so much followed in an order, but you also have GI infections like C. diff or perforated bowels. Those with prosthetic devices, so as our population grows and the number of joint replacements increases, all of those patients are at risk. And those with skin or soft tissue infections, like decubitus ulcers, those who are in nursing homes or in wheelchairs, and vascular ulcers. Next slide. So a sepsis screening, and the screening really can start out as a thought process. So which one of my patients in front of me today has my highest risk of being septic? And it should be performed routinely by nurses at every level of care, especially on admission or arrival, thinking it through. What is this patient presenting with, and could they be at risk for sepsis? At regular intervals when they're inpatient, staying with us, with any change in condition. So what is happening? What is that change in condition telling us? There are tools to help improve early recognition of sepsis, and I have one to share with you today. And then early diagnosis and treatment does improve outcomes. Next. So some early signs and symptoms of sepsis is tachypnea, respiratory rate over 20, altered mental status, altered temperature, so you could have a high or a low temp, systemic vasodilation, tachycardia, mild hypotension, which could just be 10 or 20 a drop in that person's blood pressure by 10 or 20 millimeters, and hyperglycemia. Next slide. So for the tachypnea, with the respiratory rate over 20, and with the respiratory infection being the most common cause of sepsis, it's one to really think about. It can be present but overlooked. Sometimes I think as nurses, we don't keep an accurate trend of our patient's respiratory rate. And with that being the sign that could actually tell us early on that there's a change in our patient, it would behoove us to make sure we're trending our patient's respiratory rates to look for a change, to look for something that's happening. And the reason why the respiratory rate will change first is because at the cellular level, there's changes going on related to that acid-base balance. There's hypoxia, which would be evident by your lactic acid test result when you take that. And then remember that patients who are medicated, like post-surgery with narcotics or sedatives, they'll have a depressed respiratory rate. Next slide. Altered mental status. Confusion is a common sign in infection in older adults. So just keep it on your in your head. The older woman who comes into the ER who is confused, and we look for the urinary tract symptoms maybe, but then we want to make sure that that patient isn't progressing into a sepsis episode. That patient could either be kind of mellow, or they could be anxious and restless and not really following instructions. And both of those could be a sign of altered mental status. Next. So hypotension. So when toxins start circulating in the blood vessels, the blood vessels dilate, which can cause some hypotension or a decrease in that patient's blood pressure. SIRS can cause vasodilation with a warm, flushed skin, bounding pulses, and a rapid cap refill. And if we get to where we haven't seen that and the patients come in and they're cold, clammy, and cyanotic, that is a sign of shock. Next. Decreased urine output. So when the body is going into a hypoxic state, it says, what don't I need to take care of right now while I'm taking care of this emergency? And urine output is one of it. It shuts it down to conserve fluid, to help with that hypotension that might be going on after the toxins were released. So it's important to look at trends for urine output and to really assess, like those that come into the EDs and the critical access hospital. So really, when was the last time that you had urine output, or has it been decreasing over the last couple days? Next. So mild hypotension and tachycardia, again, because those blood vessels are dilating with the toxins in them, the BP will go down, the heart rate will go up a little bit, all right? And just a reminder that patients on beta blockers and calcium channel blockers will probably not become tachycardic. So those, you have to think about that patient separately. Next. But my patient doesn't have a fever. We sometimes use fever as an indication of an infection. But as our population, the older population grows, we have to remember that not all of them will have an infection. As they get older, their thermoregulation doesn't work as well. So they could come in and be normotensive. What you don't want to see is a patient that comes in that is hypothermic, because that is a very bad prognostic sign. Next. Hyperglycemia. So that could either be a sign of stress, that there's just an infection occurring in the body, or it can be an indication that the sepsis episode is expanding. Next. An ileus. This is one that we don't think about very often. But a patient that comes in that hasn't had a bowel movement for a couple days, is their body shutting down because they have an infection and they are in the experiencing a sepsis episode? The blood is shunted away from the bowel during low perfusion stage, which that would be if there was toxins released into the bloodstream. So assessing for decreased eating, nausea, vomiting. If the patient has a tube feeding, that there would be high residuals. Vomiting and aspiration pneumonia is a common complication with this, and dead gut can occur if we don't intervene quickly. Next. Systemic inflammatory response, SIRS. Remember on that first slide where we talked about SIRS, sepsis, severe sepsis, septic shock? This has been our basis for determining if a patient has sepsis or not. But really, SIRS can happen in, it doesn't just happen in sepsis. It can happen in trauma, after major surgery, with burns, with an MI, pancreatitis. But it does help us try to isolate those patients who are at higher risk for us. So if a patient comes in, complains of a cough, maybe doesn't feel quite as well, low-grade fever, if they're tachypnic and have a temp, that would put them into the risk factor for you to think about, that I need to make sure that they're not having a septic episode. And again, I wanted to reiterate the fact that an increased respiratory rate is a key early indicator, and it's one that we often miss. Next. So acute organ dysfunction, where sepsis is now defined as an infection that has acute organ dysfunction. That can be because the patient's hypotensive, they have acute respiratory failure, and this is new for them. This is not something that they have a history of. They can have an increased creatinine, bilirubin, a decreased platelet count, an increased INR, and the most common is the increased lactic. Next. Just a little star here, because I know in critical access hospitals we do have surgery patients, and the incidence of sepsis and septic shock is more common in that post-surgery patient than a PE or an MI combined. And I know we're always looking after our surgery patients, making sure that they're breathing well and getting up to move so that they don't have a complication of a PE. But remember that sepsis is actually more common. And those, of course, at highest risk are those over age 60, those who had emergency surgery, and those with the comorbidities of liver, cardiac, pulmonary, and renal disease. Next. So prompt treatment, the Surviving Sepsis Guidelines has bundled care, and within 3 hours, your goal is to obtain a lactate, draw some blood cultures, give antibiotics, and a 30 ml per kid bolus if it's needed for hypotension. The two in red, the antibiotics and the 30 ml per kid bolus, those have been verified through research that those are the two interventions out of this whole bundled care that really can impact the outcome for the patients. So those are the ones that we really need to get on board as quick as possible. Within 6 hours, we need to repeat that lactate to see if our bolus is helping us with our system. Use vasopressors when indicated. That would be because the bolus didn't help us with our blood pressure. And then do a repeat assessment. Both nursing and physicians need to do a repeat assessment to see that those interventions that we did, that bolus, did it help or not. Next. So rapid recognition, I have an example of a cheat sheet, I guess you could call it, that we use here at Capital Medical Center, and our ED physician actually came up with this. And instead of calling it a sepsis sheet, we're labeling it an infection flow sheet. And what we're looking for is, does the patient have a suspected or confirmed infection? Do they have a couple of those SIRS criteria? And then monitor their labs, and do they have end organ dysfunction? And if they do, that's our time that we need to really get moving on our interventions. Next. Sepsis really is a race against the clock. We need to know who our highest risk patients are and screen them regularly. And we need to quickly get patients transferred to higher level of care if needed. And in the critical access world, that's probably one of your scariest moments, is when you have this really sick patient that ended up in your AD and you identify them and you need to get them to a higher level of care quickly. Next. So as IPs, it is our job to help prevent infection, knowing that the majority come from the community. That leaves us with a little bit, though, of those that can be identified as being caused, or they got their organisms in the hospital. So we need to be making sure that we do great aseptic technique with our central line placement and our dressing changes. For COTIs, limit our use of Foley catheters, make routine perineal care, and look for every reason we can to take that Foley out as soon as possible. And be careful, we don't want our patients up and being really mobile with the Foley catheter. Hopefully, if they're up and being mobile, that could be a time for it to be removed. Next. So for our vented patients, we want to make sure that we do the chlorhexidine baths, keep the head of the bed up 30 degrees, and do really great oral care for them. And then for our general surgery patients, we want to make sure that they have those antibiotics within an hour of incision cut time, that their temperature is controlled during the surgery, that their glucose is controlled post-op, and that we limit the use of prophylactic antibiotic therapy so that when we use it, it's needed. Next. And the age-old truth, yes, good hand hygiene does save lives. I tell my people here it seems silly that we need to talk about washing hands. We should have all learned that in kindergarten, but we do have to talk about it, and I have to talk about it pretty much every week to remind people that we have to wash our hands, the appropriate times to wash our hands, and to the extent that we need to do it, to do a good job to get rid of the unwanted guests that would love to stay with us. Next. Questions?
All right, and Kara, thank you for a phenomenal presentation. So what I am going to do is I'm going to unmute everyone's lines, and you can either type into the chat window, or rather the questions window, if you have any questions, or just feel free to speak up. You will all be unmuted in just a second. And I apologize about the video that wasn't working, but I will send out the link in just a bit. Okay.
So did the video not get heard very well?
I'm sorry, what was that?
Did the video not get heard very well?
No, I don't think it did.
I would love to share it with everyone because it's a really great video.
It is. All right, do we have any questions? I'm not hearing any questions, but I did just want to mention, just in listening to Kara's presentation, I think oftentimes, we talk about sepsis, but we don't talk about it in the granular level that was really provided here. And it's really important that folks really understand the causes of it and even the cellular detail that Kara provided, because that really lends to folks having a better understanding of the significance of sepsis. And, I appreciated your comments, Kara, about the host response and talking about just how sepsis is really sneaky, paying closer attention to those respirations. And talking, we are headed into cold and flu season, and if the number one source of the number one infection source of sepsis is respiratory infection, we really need to have that heightened awareness.
Yes.
Yeah. And anyone else there, have you had any successes in your critical access hospitals? And that's okay. I'm sorry, was someone trying to talk? All right, well, I'm sure you all have done great work in your critical access hospitals, and I know it can be hard sometimes on a webinar to talk about that. But before we close, what I would like to do is, as promised, I'm going to copy and paste the really impactful video that Kara provided in her presentation. And there it goes. So you should all see that. I just posted it in, and Kara did too as well. So it is posted in the questions, and we'll send that out also with our email distribution list. But want to thank everyone for attending today. I hope you really enjoyed the presentation. I know I did. Want to thank Kara for giving an amazing talk. And it is 12:48, so I think I can actually give you a few minutes back to your day. With that, I am going to close out the call. So thank you, everybody. All right, bye-bye. All right, Kara, are you still there? I'm going to